Chapter 8, Acid-Base Balance. Learning objectives. Define acids, bases, and buffers and the scale for measuring each. Identify chemical buffers and explain their role in maintaining acid-base equilibrium. Explain how to assess acid-base balance in patients. Describe the four major types of acid-base disorders, as well their possible causes and pathophysiology. Understand the signs, symptoms, and treatment of acid-base disorders. Even minor changes in pH can have significant effect on physiological function. Maintenance of a normal pH and thus homeostasis allow for normal cellular function, enzyme activity, and membrane stability. Alterations of pH at the cellular level are manifested in often dramatic systemic signs and symptoms. Acid-base imbalances can occur throughout the lifespan. During infancy, immature kidneys coupled with a high metabolic rate increase risk of acidosis. Changes in respiration result in rapid changes in carbon dioxide levels in infants due to their small lung capacities. It is crucial for the registered dietitian nutritionist to have a strong understanding of acid-base balance since many nutrition therapies, such as parenteral nutrition, impact these metabolic changes. This chapter defines acids, bases, and pH and describes conditions and subsequent treatment of acid-base imbalance. Substances that can donate or give up hydrogen ions are considered to be acids. In human physiology, two groups of acids are important: volatile and non-volatile. Volatile acids are those that can be converted to a gaseous form and eliminated by the lungs. Carbonic acid is the most important volatile acid because it is produced in the largest quantity and provides the major source of hydrogen ions. The body produces an average of 20,000 millimoles of carbonic acid daily. Because carbonic acid does dissolve so readily, it is not possible to measure its exact concentration. Instead, the concentration of carbon dioxide is used as an indirect measure of acidity. The concentration of carbon dioxide is expressed as PaCO2, which is a measurement of partial pressure exerted by carbon dioxide in blood. It is considered to be partial because additional gases present in the blood, such as nitrogen and hydrogen, also are exerted their own pressure, which contributes to total pressure. Non-volatile or fixed acids include those inorganic acids that are formed during metabolism of carbohydrate, protein, and lipid. They are produced as end products. The lungs cannot eliminate non-volatile acids. The amount of these nutrients consumed will affect the amount of fixed acids produced, but on average, 50 to 100 millimoles are produced each day. Fixed acids can be either organic or inorganic. Protein metabolism contributes the most with its addition of inorganic acids such as phosphoric acid or sulfuric acid. Examples of organic acids produced during metabolism include lactic acid and keto acids. Fixed acids are also produced as a result of starvation or fasting, fever, exercise, and some disease states. Bases are substances that can accept or receive a hydrogen ion. The most predominant base involved in human acid-base balance is bicarbonate. Other alkaline substances are added to the body through ingestion of fruits and vegetables. The kidneys provide primary regulation of bicarbonate concentration by controlling the amount of free hydrogen ions and the amount of bicarbonate that is removed or retained in the body. A buffer is a substance or a group of substances that react with either acid or base in order to decrease the effect of acid or base on the pH of a solution. The unit for measuring relative acidity or alkalinity of a fluid is called pH. Simply stated, pH is the ratio of bases. Hydrogen ion concentration is the negative logarithm of hydrogen ions. Because the scale of hydrogen ion concentration is logarithmic, in order for the pH to change by 1 unit, for example, 3 to 4, there must be a 10-fold change in hydrogen ion concentration. The pH is a substance measured in a range from 1 to 14. A 1 on the pH scale indicates the most acidic, and 14 indicates the most alkaline. Water is considered neutral at 7.0. For humans, a normal serum pH is within the ranges of 7.35 to 7.45. Note that reported normal values for arterial pH vary among the numerous references available. For this chapter, the range of 7.35 to 7.45 is used. As shown in figure 8.1, the pH of other body fluids vary, with gastric juice being the most acidic. Acidosis is the process or processes that lead to accumulation of acid or loss of base. Acidemia is the actual decrease in pH within the body to less than 7.35. Alkalosis is the process or processes that lead to accumulation of base or loss of acid. Alkalemia is the condition where an actual increase of pH greater than 7.45 is observed. In clinical practice, this distinction is generally made, and the terms acidosis and alkalosis are used to refer to abnormal pH. A buffer reacts with free hydrogen ions in order to maintain acid-base equilibrium. Effectiveness or the power of the particular buffer is determined by its association with a cellular salt and by its overall concentration in the fluid compartment. Buffers are present in all body fluids, both extracellular and intracellular. The primary buffer in extracellular fluid is the bicarbonate carbonic acid buffer system. This buffer system accommodates more than 80% of the required buffering in the extracellular fluid. As the buffer system reacts with fixed acids, carbonic acid is produced. As previously discussed, carbonic acid readily dissolves to carbon dioxide in water. Therefore, the lungs will accommodate the increased load of acids by increasing rate and depth of breathing and expiring the carbon dioxide. The kidney will help with this buffer system by either reabsorbing bicarbonate from carbon dioxide in water, The Henderson-Hasselbalch equation has been used to explain the interrelationship between carbonic acid, bicarbonate, and pH. In humans, pH, or ratio of acid to bases, 1 part carbonic acid to 20 parts bicarbonate. In order for pH to remain within the normal range, this ratio has to be maintained. If one part of the equation changes without the other and the ratio is not maintained, pH will move out of the normal range. The body has additional buffer systems in place to compensate for changes that could occur from sources of acid. An important buffer system within red blood cells and tubules of the kidney is the disodium/monosodium phosphate buffer. Excretion of hydrogen could potentially make urine so acidic that excretion would be physically damaging to the kidney. Fortunately, phosphate helps with this buffer system by either reabsorbing bicarbonate or regenerating additional bicarbonate from carbon dioxide and water. Protein present in the plasma can act as buffers. Their contribution is most important intracellularly. The protein buffer system acts in the same fashion as the bicarbonate carbonic acid buffer system, in that protein accepts the hydrogen. Many proteins can also release the hydrogen if alkalinity increases. The protein's ability to act in both situations increases the effectiveness of this buffer system. Hemoglobin within the red blood cells act as the most important buffer in blood. Carbon dioxide diffuses into the blood as it is produced throughout the body. Most of the carbon dioxide will combine with water, forming carbonic acid. Carbonic acid will dissociate to bicarbonate and free hydrogen. Hemoglobin that binds the hydrogen. I say again, hemoglobin then binds the hydrogen. The reaction is reversed as blood passes through the lungs and becomes oxygenated. Oxygenated hemoglobin gives up the hydrogen to bicarbonate, and thus carbonic acid is generated. Carbonic acid dissolves to carbon dioxide and water. Carbon dioxide is then expired via the lungs. On the usual mixed diet, pH is threatened by production of strong acids, which result mainly from protein metabolism. These acids are buffered by chemical buffers in the body. Removal of extra hydrogens and the accompaniment of anions from the body is accomplished by renal excretion. When the kidneys excrete hydrogen, they add new bicarbonate to the blood, thereby restoring depleted body buffer bases. The respiratory system eliminates carbon dioxide produced by metabolism. Carbon dioxide is not a threat to acid-base balance, provided its partial pressure in arterial blood is kept at a normal value. The chemical buffers and their primary roles are explained in Table 8.1. Please review this table on page 162. Transport and exchange of carbon dioxide and oxygen. Carbon dioxide picked up at the tissue level is transported in the blood in 3 ways. 1, physically dissolved. 2, bound to hemoglobin. And 3, as bicarbonate ion. The next line of defense is maintaining acid-base balance is respiratory control. The lungs have the ability to change respiratory rate and depth of breathing to control whether release or retention of carbon dioxide and hence assist in management of acid-base balance. This control system is very sensitive and is able to respond spontaneously. The level of carbon dioxide in the blood controls the pH of the cerebrospinal fluid since hydrogen and bicarbonate do not cross the blood-brain barrier. Changes in pH, specifically the level of carbon dioxide, are detected in cerebrospinal fluid by respiratory center in the brain. For example, when acidosis occurs and the buffer system is not adequate to control the acidosis, respiratory rate and depth will increase, causing hyperventilation. This allows larger amounts of carbon dioxide to be expired. Any change in anatomy and physiology of the respiratory system, nervous system control of respiration, or muscles that assist in breathing will affect the ability of the respiratory system to respond to changes in pH. The kidney's role in controlling both hydrogen and bicarbonate is a crucial component for the maintenance of pH homeostasis. Respiratory control is effectual in dealing with the large amounts of non-volatile or fixed acids since these cannot be expired as gases. To maintain pH, a healthy, normal functioning kidney will reabsorb the majority of all bicarbonate that is needed. This function requires the kidney to secrete hydrogen, which combines with bicarbonate forming carbonic acid. Carbonic acid dissolves to form carbon dioxide and water, which then forms bicarbonate and free hydrogen. This allows for constant regeneration of bicarbonate, which is needed to buffer the fixed acids being continuously released. In the situation where alkalosis occurs, the kidney will respond by reducing the amount of bicarbonate reabsorbed. If acidosis occurs, the kidney will increase the secretion of hydrogen and increase the amount of bicarbonate reabsorbed. The minimum pH of urine in humans is 4.5. If pH drops below 4.5, the urine acidity becomes harmful. The base ammonia is formed in renal tubule cells from the ammonia. The base ammonia is formed in renal tubule cells from the amino acid glutamine. Free hydrogen combines with ammonia. In situations where a large load of fixed acid is produced, the kidney will respond by increasing formation of acids within this buffer system. This may occur, for example, during protein catabolism. Hydrogen ions and bicarbonate are both electrolytes. Acid-base changes will therefore affect concentrations of other electrolytes in both extracellular and intracellular fluids. For example, movement of bicarbonate to the plasma requires the exchange of another negatively charged ion so it is maintained. Chloride is the ion that moves the opposite direction of bicarbonate. Changes in potassium, chloride, and sodium may accompany acid-base disorders. It is an understatement to say that assessment of acid-base disturbances may be difficult. This difficulty arises because of the body's attempt to self-correct changes in pH. These secondary responses confuse the clinical situation, making origin of the disturbance difficult to assess. Assessment of acid-base balance requires more than simply examining laboratory values. It needs to be placed into the context of the patient's current medical condition. Examining laboratory values elicits only the current state of blood pH. Common laboratory measurements of arterial blood gases and serum chemistries will provide values needed to initially assess acid-base balance. Please review Table 8.3 on page 165 for an outline of normal values of arterial blood gases, parameters, and analysis of arterial blood gases. There are 4 major types of simple acid-base disorder: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Combinations of each of these indicating a mixed disorder can and often do occur. The only combination of imbalances that is not a possibility is respiratory acidosis and respiratory alkalosis, since obviously hypoventilation and hyperventilation cannot happen together. Respiratory acidosis occurs when there is an excess of acid in relationship to base caused by retention of carbon dioxide. This generally occurs when there is an inability of the lungs to expire carbon dioxide. As the level of carbon dioxide rises, more carbonic acid is formed and pH is shifted towards acidosis. Any factor that inhibits the respiratory center can affect ventilation and thus the ability to release carbon dioxide. Medications such as opiates or sedatives can inhibit respiration. Chronic conditions such as sleep apnea or acute events such as cardiac arrest can also affect normal ventilation. In respiratory acidosis, the major cellular buffering defense available is expiration of carbon dioxide by the lungs. But since the major cause of respiratory acidosis is respiratory dysfunction, this buffering system is typically inefficient. During respiratory acidosis and acute respiratory acidosis, the kidney regulatory systems do not have time to compensate, since this only begins to react within 12 to 24 hours. Chronic respiratory acidosis is less critical because the kidneys have more time to provide for ongoing compensation. Renal compensation, which works over a longer period, includes increased excretion of hydrogen and reabsorption of bicarbonate. Other renal buffer systems, such as the use of ammonia, will also provide a secondary response. Laboratory values in acute respiratory failure will indicate a decreased pH and an elevated partial pressure of carbon dioxide. Bicarbonate levels will be slightly elevated if renal compensation has begun. Compensatory mechanisms or secondary responses allow the pH to remain normal, but serum bicarbonate and arterial partial pressure of carbon dioxide are elevated. In both acute and chronic respiratory acidosis, hypoxemia is present. This reduced level of oxygen is responsible for most symptoms associated with acidosis. Alterations will include increased respiratory rate, hyperventilation, and an increase in depth of respirations. Other symptoms are result of change in oxygenation in the brain and or decrease in neurotransmission. These include restlessness, muscle twitching, tremors, and or a coma. Below are common causes of respiratory acidosis: hypoventilation, chronic obstructive pulmonary disease or COPD, a pneumothorax, certain drugs such as sedatives or opiates, morbid obesity, excessive production of carbon dioxide, overfeeding, especially with high carbohydrate components of nutrition support. Treatment will focus on correcting the underlying condition causing respiratory changes. Presence of hypoxemia would focus treatment on increasing oxygenation through administration of oxygen or provision of mechanical ventilation. In those patients with chronic hypoxemia, it is crucial to realize that the hypoxemia may be providing the stimulus for ventilation. If oxygen therapy reduces hypoxemia, ventilation may acutely decline without this stimulus. Respiratory alkalosis is characterized by a relative excess amount of base bicarbonate as a result of reduction of carbon dioxide. This acid-base disturbance is generally a result of conditions causing hyperventilation. Rapid breathing results in a decreased partial pressure of carbon dioxide. Hyperventilation is commonly a result of a reduction in serum oxygen level, hypoxemia. Hypoxemia can be a result of respiratory diseases such as pneumonia, asthma, pulmonary embolism, or pulmonary edema, and or the exposure of high altitudes. Direct stimulation of the respiratory center in the brain can also cause hyperventilation and resulting loss of carbon dioxide. For example, disorders of the central nervous system, such as a stroke, can affect respiratory centers and result in hyperventilation. Hypermetabolic states, such as seen in fever or sepsis, can directly stimulate hyperventilation. Hyperventilation can also occur as an adaptive response to high oxygen demands during strenuous physical activity. The acute response to respiratory alkalosis is a shift of acid from the intracellular fluid to the extracellular fluid with an accompanying movement of bicarbonate into cells in exchange for chloride. In acute respiratory alkalosis, pH is greater than 7.5 and partial pressure of carbon dioxide is decreased. In chronic respiratory alkalosis, pH is greater than 7.5 and plasma bicarbonate is low. Other symptoms of respiratory alkalosis are seen in cardiovascular, central nervous, and respiratory systems. Cardiac arrhythmia may be noted. Symptoms of the respiratory system vary, but may include frequent yawning and deeper breaths. Symptoms of the central nervous system are more obvious and may include lightheadedness, mental confusion, anxiety, and seizures. Correction of the underlying cause of respiratory alkalosis is the only significant treatment. Correction of hypoxia may be done by providing oxygen therapy is the first common step. Metabolic acidosis refers to all types of acidosis that are not caused by excessive carbon dioxide. It can result from either excessive loss of base or an excessive gain of fixed acids. Metabolic acidosis can develop in both acute and chronic conditions, but do cause respiratory compensation. It is most often a chronic condition. Conditions that result in excessive loss of bicarbonate from the gastrointestinal system or from renal excretion of bicarbonate can result in metabolic acidosis. Diarrhea is the most common cause. Additionally, bicarbonate may be lost. Additionally, bicarbonate may be lost. Additionally, bicarbonate may be lost from an ileostomy or from a pancreatic, biliary, or interstitial fistula. Metabolic acidosis may also result from situations that increase the amount of acid, such as rapid administration of IV saline. Lactic acidosis occurs as a result of increased production of lactic or keto acids. High levels of lactate may result when the kidney or liver fails to convert lactic to pyruvate. Diabetic ketoacidosis, one of the most common causes, results in metabolic acidosis due to both increased production of and inability to metabolize ketones. In both starvation and chronic alcoholism, synthesis of keto acids is increased. When hydrogen levels increase, the bicarbonate carbonic acid buffer system is stimulated. High levels of hydrogen in the blood stimulate respiratory centers in the brain. The lungs respond by increasing rate and depth of breathing. The kidneys begin their compensatory response by increasing their excretion of hydrogen and retention of bicarbonate. Renal compensation is much slower than respiratory, and if kidney disease is present, effectiveness of the compensation is decreased. Symptoms of metabolic acidosis are not as clear as those of other acid-base disturbances. Changes in respiration include deep labored breaths, which are referred to as Kussmaul breathing. The cardiovascular system is affected by decreased contractility and decreased contractility. Treatment is focused on the underlying cause of acidosis. Correcting pH too quickly can cause additional complications. The goal is to rise systemic pH to a safe level. Presence of an excessive amount of base results in metabolic alkalosis. Generally, this acid-base disturbance is caused by a loss of non-volatile acids or the excessive administration of bicarbonate transfusion within whole blood. Clinical situations resulting in alkalosis can be categorized as either conditions involving fluid imbalances or those without fluid imbalances. Conditions that involve fluid imbalances include prolonged vomiting, nasogastric suction, or use of diuretics. Nasogastric suction may be seen in post-operative patients who are experiencing ileus. The nasogastric suction removes gastric secretions in prevention of vomiting or aspiration. Initiation of metabolic alkalosis begins with the underlying event that causes whether an excessive loss of acid or accumulation of base. In situations where there is also volume depletion, such as in the use of diuretics, there is both a fluid loss and a subsequent decrease in potassium levels. To maintain serum potassium levels within safe range, the kidney will excrete hydrogen in exchange for potassium. Even though potassium may increase, the loss of hydrogen results in generation of more bicarbonate. This further contributes to alkalosis. Arterial blood gases in metabolic alkalosis will indicate a pH of greater than 7.45 and elevated of bicarbonate. There are no specific signs and symptoms for metabolic alkalosis. Signs and symptoms are determined by accompanying conditions of volume deficit or electrolyte abnormalities. For example, in the situation where there is hypokalemia and a decrease in extracellular fluid, the patient may experience muscle cramping, weakness, and cardiac arrhythmia. In chloride response metabolic alkalosis, correcting volume imbalance with isotonic saline with added potassium chloride will correct alkalosis. Metabolic alkalosis that does not involve a volume deficit requires treatment of underlying causes before alkalosis can be corrected. Several acid-base disturbances can coexist in complex medical problems. For instance, this may occur in a patient who is respiratory compromised and is unable to respond to a situation producing a metabolic disorder. This could also occur in a situation of drug overdose where different medications cause both respiratory and metabolic responses. When examining arterial blood gases, a mixed disorder should be suspected when partial pressure of carbon dioxide and bicarbonate are not consistent with the measured pH. A mixed disorder may also be present when secondary response is exaggerated. For example, metabolic alkalosis and respiratory acidosis may occur when a patient with chronic obstructive pulmonary disease, COPD, receives diuretics. Table 8.10 gives examples of common mixed acid-base disorders. Metabolic acidosis plus respiratory acidosis. Examples: cardiopulmonary arrest, patient with COPD goes in shock, patient with DKA receives potent opiate. Metabolic acidosis plus respiratory acidosis, patient with previously compensated respiratory acidosis caused by COPD over-ventilated on mechanical respirator. Head trauma patient with hyperventilation treated with diuretics. Metabolic acidosis plus respiratory alkalosis. Lactic acidosis complicating septic shock. Metabolic acidosis plus respiratory acidosis. Patient with COPD who is vomiting or who is treated with nasogastric suction or potent diuretics. Adult respiratory distress syndrome. Conclusion: remembering basic concepts related to acid-base balance will keep you on track in evaluating these complex clinical situations. The scale for measuring acidity or alkalinity of a fluid is the measurement of pH. pH is the ratio of bases to acids. Normal pH in humans is 7.35 to 7.45. The pH is maintained in a ratio of 20:1, base to acid within body fluids. There will be no change in pH if the ratio remains stable, but changes in either portion of the ratio result in changes in pH. The largest source of acid within the body is carbonic acid. We measure concentration of carbon dioxide as an indirect measure of acidity. Concentration of carbon dioxide is expressed as PaCO2. The lungs are the primary regulator of carbon dioxide levels. The largest source of base is bicarbonate, which is regulated primarily by the kidneys. Respiratory acidosis is a result of retention of carbon dioxide, whereas respiratory alkalosis is a result of hyperventilation and subsequent decrease in carbon dioxide levels. Metabolic acidosis occurs when there is a retention of fixed acids or excessive loss of bases. Metabolic alkalosis is a result of excessive loss of fixed acids or retention of base.